What should you do as a primary provider when your creatinine goes up after starting an ACE inhibitor or angiotensin receptor blocker? Well, these are questions we get a lot in our nephrology clinic. I'm Dr. James Hall, a nephrologist, and we're going to talk about ACE inhibitors and the angiotensin receptor blockers. These are great drugs for blood pressure, great drugs for people who have chronic kidney disease and diabetic nephropathy, but they do have their side effects. A lot of times when you start an ACE inhibitor or angiotensin receptor blocker, you'll notice that the creatinine will go up. What do you do about it? Well, today we're going to talk about that. We're going to talk about what to do about other side effects. And the third thing we're going to talk about is what to do about potassium hyperkalemia when you start ACE inhibitors and ARBs. Is that a contraindication? The first thing is when you start an ACE inhibitor or ARB, your efferent arterioles in your kidneys get relaxed, and that lowers the GFR. That lowers your renal blood flow somewhat, and that lowered renal blood flow will lower your GFR or increase your creatinine. So when you see that in clinic, typically you should think maybe this patient has an acute kidney injury from this drug. Maybe this patient is allergic to this drug. Or maybe this is something else going on with this patient. Maybe it's renal artery stenosis. So the magic number for you to keep in mind is 30%. If you put a patient on an ACE inhibitor or ARB and their GFR drops less than 30%, their creatinine rises less than 30%, then you can keep the patient on that drug. That less than 30% is actually renal protective. So that change in GFR lowers the glomerular pressure, so to speak, and it takes pressure off the glomeruli, and it decreases proteinuria by lowering the glomerular pressure. I'm kind of simplifying it, but I want you to know that if you put a patient on one of these drugs and their GFR drops by less than 30%, it drops by 20%. Well, that's renal protective. That's what we want. That's a predictable drop in GFR because we know these drugs are going to lower the efferent. They'll lower the renal blood flow and lower the intravenous pressure, which lowers GFR. Now, if you put a patient on these drugs and their GFR drops more than 30%, their creatinine rises more than 30%, that tells you this patient could possibly have a renal artery stenosis, and you probably should stop the drug. 30% is my cutoff. If I notice a patient's creatinine rise by more than 30%, I will stop the ACE inhibitor or angiotensin receptor blocker. I believe most nephrologists will also do that because we're kind of creating harm and we're dropping the GFR significantly, and that warrants further indication. Most patients, when we see that, we'll work them up for renal artery stenosis by getting a renal angiogram and just checking them for any type of other renal vascular related issues that may be causing them to experience that significant of a drop in GFR. The next thing, what to do about other side effects? Well, we have a lot of patients who have a dry, hacky cough on an ACE inhibitor. Patients like that, you can switch them over to an angiotensin receptor blocker. The ACE inhibitors have a tendency to increase histamine levels and make you cough like crazy. So you can switch them over to an ARB if you need to, which don't have that same side effect. Sometimes you can have life-threatening angioedema and anaphylaxis. We saw a lot of this when the ACEs first hit the scene, and we had a lot of patients in the ICU, on the ventilator, on steroids and antihistamines to try to prevent and reverse this process. Sometimes you can have dizziness in some patients on ACEs. Some of the ARB side effects is hypotension. Angioedema is a risk, but it's much lower compared to your ACE inhibitors. And another phenomenon we see with the angiotensin receptor blockers is ARB-induced enteropathy. Your patients will come in with some type of GI illness, chronic diarrhea. They may have some weight loss, some fatigue, some abdominal pain, nausea, bloating. It's rare. And I think I may have seen it once in my probably 20 years of practice. It's probably missed more so than diagnosed, but keep that in mind on a patient who you start on an ARB. They may have this enteropathy related side effect. And finally, the last thing that I want to talk about is hyperkalemia. What do you do about hyperkalemia in patients on angiotensin receptor blockers or ACE inhibitors? Is hyperkalemia a contraindication to continuing these drugs? It's relative. If the potassium is really high, obviously you got to stop the potassium. If it's relatively high, 5.5 to 6, and your patient really needs to be on this drug? Cases like that I always take on an individual basis. A patient who has a potassium of 5.8, they're on an ACE inhibitor, they have congestive heart failure, diabetes, and maybe some diabetic nephropathy. A patient like that, I would love to keep them on that ACE or ARB. So I would actually add Lokelma or Veltazza or one of the potassium lowering agents to try to continue to reap the benefits of that ACE inhibition. Now I know I don't like starting another medicine for a problem that we have caused from another medicine, but some conditions warrant that. Some conditions are unique and complex, so we have to take them on an individual basis. And that's where you need your nephrologist and your cardiologist involved. As a primary provider, you guys are on the front lines, and I want to help you manage your patients like a nephrologist. That's why we've created this online nephrology course that's 7 modules with quizzes after each module to help you get better at managing these types of patients. Check out the free webinar below if you want to. But back to hyperkalemia. Typically, I'm very careful when I start patients on ACE inhibitors and ARBs. I will usually check the potassium and the creatinine 2 to 3 weeks after starting an ACE or ARB, especially if I think the patient is going to be hyperkalemic or if their GFR is going to drop in response to that medication. Now, this video basically kind of encapsulates a small snapshot of how to manage ACE inhibitors and ARBs in CKD patients. Normal renal function patients do well on ACEs and ARBs, but you still have to keep what we talked about today in mind. The main 3 things we talked about: what to do about a drop in GFR when you start an ACE and ARB, what to do about other side effects, and also what to do about hyperkalemia in patients on ACEs and ARBs. One last thing I'll give you, ACEs and ARBs are not a contraindication in end-stage kidney disease. You definitely need to watch that potassium level, but we like to keep patients on these agents even when they kidney function is below 15%. So check us out, check our webinar, check our community out. We do have a community where you can send me real life questions and I can answer them for you and just give you some inside information on what we nephrologists do. I hope this video was helpful to you, and I will see you in the next video. Thank you. Bye.